Good morning, everybody. So I have the pleasure of introducing Dr. Chowdhury. She's going to be discussing hypertension and stroke. She is board certified in internal medicine and nephrology. She received her medical degree from the American University of the Caribbean School of Medicine and completed her residency at Lutheran Medical Center and completed her fellowship at Christiana Care. So welcome, Dr. Chowdhury.
Thank you for having me today. Can everyone hear me? Okay. So I'm going to be speaking about stroke and hypertension today. All right. Right. I'm not sure what happened to the slide, but I wanted to just go over the objectives of my presentation today. First, I'd like to review the epidemiology and the natural history of hypertension based on some of the earlier hypertension clinical trials. Then I'll review the evidence-based risk factors for stroke. Then I will discuss some of the key clinical trials in hypertension. Fourth, I will discuss the proven non-pharmacological intervention for prevention and treatment of hypertension. And lastly, I'll review the evidence of ACC and AHA blood pressure guidelines in secondary prevention of stroke. Before we start, I wanted to read out this one statement that was made by Dr. Kaplan in a commentary that he made for the JNC 6 guideline in 1998. The measurement of blood pressure is likely the clinical procedure of the greatest importance that is performed in the sloppiest manner. And this statement really stood out to me because we all know how important blood pressure is, but we also know how we unfortunately measure it in the clinic setting, especially when we have a 15 to 20 minute window to have the patient checked in, seen, and have a assessment by the end of the visit. So we know that the first thing they actually do when they come in is check their blood pressure, and it is not done in the appropriate manner that it should be done. And by that, I mean, we all learned in medical school or beginning of our medical career how blood pressure should be measured. But like I said, it's not done this way. So I just want to briefly go over, just as a reminder, how blood pressure should be taken. So before you measure blood pressure, as everyone remember, you should avoid caffeine, smoking, exercise for at least 30 minutes, sit quietly for at least 5 minutes in a chair, not the examination table. While your blood pressure is being measured, you should sit with both of your feet flat on the floor, not legs crossed. Make sure that the arm is being measured is supported at heart level by your chest and stretched out. Your back should be supported so you can rest comfortably and do not talk. This is another slide just reiterating those processes that should be done. So today, I know everyone knows the risk factors for stroke, the traditional risk factors, which are hypertension, diabetes, hypercholesterolemia, smoking, physical activity, and alcohol intake. But I'm not talking about stroke and diabetes today or stroke and hypercholesterolemia today, but rather I'm talking about stroke and hypertension. And why is that? So this is actually a summary. I know it's a busy slide and I don't know if everyone can see it clearly, but I'm just gonna briefly go over what this slide means. So these are all the risk factors and some more in addition to what I just mentioned in the previous slide for stroke. And I want to bring your attention to the second column, which discusses the interstroke trial. This is a study that was done in over 32 countries, and it had more than 13,000 cases. and it was sex match controls in patients with no previous history of stroke. The study was conducted from 2007 to 2015. The study identified 10 potential modifiable risk factors that were associated independently and significantly with stroke. However, hypertension was the most common risk factor, and it was it's the PAF, which is the population attributable fraction of stroke, was almost 99% for this trial. And same thing goes for this third column, which is the sub-Saharan African sarin trial. It had more than 2,100 cases. Again, hypertension being the number one risk factor for stroke. Same goes for this Indonesian study and so forth. Hypertension is present in all cardiovascular disease. It's present in myocardial infarction, it's present in heart failure, peripheral vascular disease. However, it is nearly 77% of patients with first stroke. So this is the data from NHANES 3. What this slide is showing is that as we get older, both systolic and diastolic blood pressure continues to trend up. But by the age of 50 to 59, systolic blood pressure continues to rise, but diastolic blood pressure trends down. And one of the reasons is due to decreased vascular compliance. So I know this is another busy slide, but let me explain it. So this is the result of meta-analysis of 61 prospective observational studies on deaths from vascular disease in almost 1 million individuals with no known vascular disease. 70% of the participants were from Europe, 20% from North America or Australia, and rest from Japan or China. The individuals were divided into 5 different categories, from the age of 40 to 49, 50 to 59, 60 to 69, and so forth. And what this is showing is that the usual blood pressure starts at each of the decade is plotted in 10 millimeter increments. This shows the relationship of stroke mortality with usual blood pressure is strong and direct at all ages above the blood pressure of 115 over 75 millimeters of mercury. So up to this point, we have strong evidence to establish hypertension is the most important risk factor for stroke. Now the question is, does reduction of blood pressure reduce the incidence of stroke, and what is the blood pressure goal? So this is the 2017 ACC and American Heart Association blood pressure goal. On this side, you can see the categories of blood pressure in adults: the normal blood pressure, the elevated blood pressure, both systolic and diastolic, and stage 1 hypertension and stage 2 hypertension. And this is the corresponding value of systolic and diastolic blood pressure for clinics, home, daytime, nighttime, and 24-hour ambulatory measurement. What I mean by that is, so if your blood pressure is 120 in clinic and at home it should be at least 120 over 80 and so on. But if your blood pressure is 160 at home, if it's greater than 145 over 90 at home, that means you have high blood pressure. So next, what I want to do is briefly discuss the results of some of the earlier landmark trials that are out there. So first, I'll discuss the VA Cooperative Study 1, which was published in JAMA in 1967. Then I'll discuss the VA Cooperative Study 2 in JAMA from 1970, the Systolic Hypertension in the Elderly Program from JAMA in 1991, Systolic Hypertension in ERO from Lancet of 1997, Hypertension in the very elderly from NEJM from 2008. So this is the VA1 cooperative study. It was a randomized double-blinded placebo control trial. It was actually a very small trial, only 143 participants, and some 66 were Caucasian and 77 were African American. The mean age was only 51.4. I just want you to keep that in mind. And this study only looked at actually diastolic blood pressure, which was 115 to 129. And the therapy used for treatment was hydrochlorothiazide, reserpine, hydralazine, and the study period was 24 months. Because of the results that they were finding for the treatment group, the study was actually terminated early. So they stopped the trial because there were so many complications in the placebo group. This slide is showing all the terminating events: dissecting aortic aneurysm, sudden death, ruptured aortic aneurysm. This slide is showing that the natural history of this is what would happen if blood pressure was left untreated. And this is the result. For the placebo group, there were 26 cardiovascular events, and for the active treatment group, there was only one cardiovascular event. What I want to really point out here is the stroke. Even though it's a small number, still the placebo group had 4 strokes and the active treatment group only had 1. This is the VA cooperative study 2. Again, this was a randomized double-blinded placebo-controlled trial. It had slightly larger group, 380 were all males. And again, this study also focused on diastolic hypertension, 90 to 114. The median age was about 48 to 49, and 44% were African American. And the pre-randomization blood pressure was anywhere from 162 to 165 and 103 to 104. They were treated with the same medications that they were treated in the study 1, and duration was 3.2 years. This is again showing the result of the cardiovascular events that took place. For the placebo group, it was 81. And for the active treatment group, there were 30 cardiovascular events. Again, I just want to bring to your attention, there were 20 strokes in this placebo group, and for the treatment group, there was 5. So there was reduction in every criteria as you can see. So in summary of these 2 trials, compared to the placebo, antihypertensive medication reduced mortality in male with diastolic hypertension. The next study that I want to go over is the SHEP trial, which looked at prevention of stroke by antihypertensive drug treatment in older persons with isolated systolic hypertension. The objective of this was to assess the ability of antihypertensive drug to reduce fatal and non-fatal stroke in isolated hypertension. This was also a multi-center, randomized, double-blinded, placebo-controlled trial. This was actually a fairly larger study, more than 4,700 participants, and this did include males and females. Actually, females were greater in this study, and the mean age was actually much higher. As you may remember, the other 2 groups, they were in the late 40s, mid to late 40s. And the average blood pressure that they looked at was 170/77. And these patients were treated with chlorothalidone and atenolol. And the way they designed it, if systolic blood pressure was greater than 180, then they reduced it to less than 160 millimeters of mercury. If the blood pressure was between 160 to 179, then they reduced it by at least 20 millimeters of mercury. And the primary endpoint of the study was non-fatal and fatal stroke. And the secondary endpoint was cardiovascular, coronary morbidity, mortality, and all-cause mortality and quality of life measures. Follow-up was 4.5 years, and the achieved blood pressure at the end was 155 for the placebo group, and for the intervention group, 143 millimeters of mercury. SHEP trial is the first trial to test the efficacy of antihypertensive treatment on clinical endpoint in persons with isolated systolic hypertension. This was published in 1991. And this is the mean systolic and diastolic blood pressure by treatment group. So this column is the active, and this is the placebo group. And this is the top half of the chart is systolic blood pressure, the bottom is diastolic. As you can see from the baseline of 170 systolic blood pressure, by year 5, it was down to 144 for the active group, and for the placebo group, it was down to 155. And there was also some reduction in diastolic blood pressure as well. So in summary, you can see that the primary outcome, which was fatal and non-fatal stroke, for the placebo group compared to the active treatment group, there was certainly a reduction in fatal and non-fatal stroke. I want to stress again that controlling hypertension is very, very important in prevention of stroke. I think it's more important than other cardiovascular events such as MI. Not to say that it's not important in those instances, it certainly is, but I think that it's more important in stroke to control the blood pressure. This is the Cystero trial. Again, this was a randomized control trial. It had comparable numbers, 2,200, a little bit more than 2,200 in the placebo, and the active group of almost 2,400. And they were treated with calcium channel blocker first, then ACE inhibitor, then diuretic. And the aim was to reduce systolic blood pressure by at least 20 millimeters of mercury to less than 150 millimeters of mercury. And the entry blood pressure was 173. And they actually reduced the blood pressure, systolic blood pressure, by nearly 23 millimeters of mercury, and diastolic blood pressure by 7 millimeters of mercury in the active group. And again, the stroke reduction was 42% compared to the cardiovascular mortality, which was 26%. And this is the HIVET trial. This is a study done in the UK for participants above the age of 80. And the inclusion criteria, again, patients were above 80, systolic blood pressure between 160 to 199, and diastolic blood pressure less than 110. What I want to stress is that these were actually good functioning patients. They were not in nursing home, they did not have dementia, and they did not have any stroke in the last 6 months, and their standing blood pressure was less than 140. These patients were divided into placebo and treatment group, and these patients were treated with ACE inhibitor and diuretic. And this was actually quite large as well, more than 3,800 patients, and the target blood pressure was 150/80. This study too was terminated early after 1.8 years due to the significant result in the treatment group. As you can see, the blue line is the placebo and the red is active treatment. There was certainly a reduction in fatal and non-fatal stroke, death from cardiovascular disease, death from any cause, and death from stroke as well. This was actually an unexpected finding of this trial, that there was a reduction in heart failure as well. This is a summary slide of the studies that I just reviewed. The SHEP, Cystero, Cis China, which I actually didn't discuss, and HIVET. What I really want to point out here is that these are all the inclusion blood pressure on the top row that you see, 160 to more than 200 diastolic in the 90s to 100 range. The goal blood pressure was either ranged anywhere from 150 to 160 or reduction of more than 20 millimeters of mercury. And the mean achieved blood pressure, I actually forgot to put it here for the CIS China, were all in the 140s to 150s and diastolic in the 60s and 70s. So certainly there was a significant reduction in every one of the studies. So some of the investigators argue that there should be further reduction in blood pressure in patients with stroke. So they recommend that blood pressure should be more intensely controlled for more favorable outcome for those patients with stroke. And these are some of the studies that demonstrate that. I am not going to discuss those studies today, but the CORD, the DREAM, and the Navigator trials. Sorry. Actually, I'm missing a few slides. I'm not sure. I'm not sure what happened, actually. I don't know if this was actually the first, but I apologize, but there were actually a few other things that I wanted to discuss here today, and that's not on my presentation, but I'll just briefly go over it because I think this is one of the questions that I have. Some of the non-pharmacological intervention. So I want to discuss two primary things here. First is weight loss. There was a meta-analysis of randomized controlled trials showing reduction in systolic blood pressure and diastolic blood pressure for approximately 1 millimeters of mercury for each kilogram you lose. So for every kilogram of weight that can be lost, you can reduce your blood pressure by 1 millimeters of mercury. So if a patient can lose 10 kilograms, they can actually come off one blood pressure medication or not even start. So I think this is very important for us to emphasize this to our patients who are coming in with high blood pressure. The second thing that I want to discuss is diet. One of the study that's out there, DASH diet, it was a multi-center randomized controlled trial that included patients of at least 22 years of age with average blood pressure of 120 to 159, with diastolic blood pressure of 80 to 95, not on any antihypertensive medications. So the subjects were put on 3 levels of sodium consumption. There was high sodium consumption of 150 millimoles per day. This is the typical Western American diet that most of our patients are on. The intermediate diet, which is 100 millimole per day, which is actually the upper limit of what's recommended, which is 2.9 grams per day, and the lower limit, which is less than 50 millimoles per day. And there were two groups of patients. The control diet was the patients who are on, again, the typical Western diet, and the DASH diet, which consists of fruits, vegetables, low-fat dairy food. It also included whole grain, fish, poultry, less of the red meat, and larger amount of potassium, calcium, magnesium, dietary fiber. What this study found was that there was certainly a difference between the 3 levels of sodium intake, the high, the intermediate, and low, but there was also a lower blood pressure reading for those patients who are on the DASH diet. So it's not only important to emphasize to our patient to lower sodium intake, but also to lower the saturated fat, eat more fruits and vegetables. This will also be very important in reducing their blood pressure. But other things like, of course, exercise, especially aerobic exercise, can lower blood pressure by anywhere from 5 to 8 millimeters of mercury for patients, not only with hypertension, but if you even have normotensive blood pressure, weight loss can lower your blood pressure for those patients who are normotensive by 2 to 3 millimeters of mercury. And with exercise, anywhere from 2 to 4. So coming back to this busy slide here, this is the ACC and AH guideline. This is for the patients who have acute ischemic stroke and elevated blood pressure. By acute, I mean less than 72 hours. So patients who qualify for IV thrombolysis therapy. I will not discuss this part. I'll leave it to the neurologist. But what I want to emphasize here is those patients who do not qualify. So if their blood pressure is less than 220 over 110, initiating or reinitiating treatment for hypertension within the first 48 to 72 hours after acute ischemic stroke is ineffective to prevent death and dependency. This actually causes more risk than benefit. So they suggest that if your blood pressure is less than 220 over 110, you should not lower blood pressure in the first 48 to 72 hours. However, if your blood pressure is greater than 210 over 100, 220 over 110, then you should reduce the blood pressure by 15% in the first 24 hours. So this CADIS trial actually just reemphasizes that. This was done in China. It included about a little more than 4,000 patients. Patients who did not have TPA in the first 48 hours were not included. And the blood pressure, they included patients with blood pressure more than 220 over 120. And they categorized these patients into control and anti-hypertensive treatment group, and they lowered the blood pressure from 166 to 144 for the treatment group, and they reached a systolic blood pressure of 137 for these groups. And the primary outcome did not differ in both groups. So what I mean is that the primary outcome between the treatment group, the antihypertensive group had 683 events versus 681 events in the control group. This was at 14 days of hospital discharge and at 3-month follow-up. So these are our TIA patients, patients who are presenting a stroke for greater than 72 hours of symptoms. So if they were previously diagnosed with hypertension, the goal is to restart those medications, aim for blood pressure of 130 over 80. For patients who did not have established hypertension, goal is to initiate blood pressure and again, aim for blood pressure less than 130 over 80. So this is the orange tab, which correlates with this, which shows that there is more benefit than risk for these patients who have stroke or any symptoms that presents for more than 72 hours. And one of the studies that they cited is this trial called the PATS trial, which was a randomized double-blinded placebo-controlled trial, which aimed at determining whether antihypertensive treatment could reduce the risk of fatal and non-fatal stroke incidents in patients with a history of stroke or TIA. And it had more than 5,600 subjects. And the trial finding indicated that patient with a history of stroke or TIA, reduction of blood pressure by 5 to 2 millimeters of mercury with indapamide reduced incidence of fatal and non-fatal stroke by 29%. So, sorry. So it's important to have accurate blood pressure measurement for diagnosis and treatment of hypertension. The risk of developing hypertension and stroke increases with age. The blood pressure is the most important modifiable risk factor for stroke. Studies show blood pressure reduction confers more benefit for prevention of stroke than prevention of heart disease. And ACC and AH hypertension guidelines recommends blood pressure less than 130/80 for secondary prevention of stroke. Any questions?
The diet opposed to the weight loss, is there one that is?
Yeah, weight
than the other?
weight loss is,
Okay.
I think it has more benefits. Studies have shown that weight loss has more benefits because the more you lose, for somebody who is morbidly obese or even overweight, the more you lose, then you can reduce the blood pressure even more. But the sodium reduction, you can only go down so much on sodium, and change that. And it's also very difficult to do that on a day-to-day basis, whereas with weight, you can lose 10, 20, 30 kgs, if willing, if need be.
As a practicing physician, how would you recommend that they deal with this issue? Because we know that visits are shorter these days and most insurances don't cover nutritional consultation.
So in terms of diet,
Yes.
it's, the way I counsel my patients is if they're already on one blood pressure medication and they say, you know what, how do I come off of it? I tell them that, it's important for you to have, this not only impacts you physically in terms of prevention of stroke and other myocardial infarction and events, but you can come off this antihypertensive medications. And the same way I counsel them when I am adding a second medication because I can't get their blood pressure. I can't say that all my patients follow my advice, but I do every visit, I do review what diet they should be on. I review how they should be reading food labels. I always say avoid canned products because it has salt that you don't even see being added. Go for the frozen or the fresh. Try to cook for yourself. When you're going out to eat, go for the low sodium part of the menu. So these are some of the things that I just emphasize and reiterate every time they come in. Some patients do follow those recommendations and others don't. But unfortunately, you're right. Insurance companies don't cover dietitian, nutrition, I think as physicians, we just have to, and nurse practitioners, we just have to review those recommendations over and over again when they come to visit.
So there's a question from our virtual audience. In the studies, it appears that systolic BP was brought to the 140s. Why is the goal to be in the 130s? Is it significant and proven to demonstrate that level of reduction?
So these were the earlier studies were done before the 1990s. And some of the later studies are showing that reduction of blood pressure is better, more favorable, less than 130/70. Those are the newer studies that are showing. Also, keep in mind, these patients are much older because the earlier studies, the patients were much younger that they looked at. So these patients are living longer, they're more elderly. So obviously, we have come a long way for the median age, how it changed from 49 to 70s now. So I think that's why we have that further recommendation. Again, everyone, if you probably speak to the earlier authors, if they were alive, they wouldn't agree that controlling it so intensively is recommended, but some of the newer authors do believe that intense blood pressure control is better.
One more question in the chat, and then I think we'll move to our next presenter. If blood pressure is slightly above 120/80, for example, 120/29/80 to 85, is that really hypertensive?
So it depends. Are these measurements at home, or are these measurements in clinic? If they're in clinic, I tend not to trust it because of the way we measure blood pressure. Like I said, they are probably rushing to get to your appointment, and that's probably the first thing that we slap on their arm, and we check the blood pressure right away. We don't give them an opportunity to settle down and, rest for 5 minutes. But if these are the blood pressures at home, I probably would be a little bit more not concerned, but have them check their blood pressure maybe at different times of the day and kind of keep a log and see what the blood pressure measurements are like. If they are in the 120s to 129, that means that they just, they can make some lifestyle modification and lower that blood pressure much easier. And I don't think that's the criteria for elevated high blood pressure or hypertension, but these are patients that needs to be monitored a little bit more closely. Maybe in the next 6 months to a year, their blood pressure can go up.